So we are going to go to next talk, and I welcome Dr. Lot Aronson, who is an MD, and she's working in the Department of Gynecological Oncology, Netherlands Cancer Institution. She's a researcher and she's studying the implementation of HIPEC in ovarian cancer. She has a master's in medicine from Leiden University, and she also has a master in transplantation from Rotterdam. Thank you very much for accepting our invitation, and we're looking forward for your talk. Please go ahead.
Thank you for the introduction. Thank you for the very kind invitation to speak at this webinar. My name is Lot Aronson and I'm a medical doctor and clinical researcher at the Netherlands Cancer Institute. And together also with my colleague Ruby van Stijn, who you just heard giving her presentation, I'm the study coordinator of the OVHIPEC 2 trial. So I would like to introduce to you this second trial that's currently recruiting patients since the 1st of January of 2020. So we've already heard a lot about the OVHIPEC 1 trial and its results and its implementation in the Netherlands. And of course, its benefits for patients with ovarian cancer. And in this second trial, we investigate whether these advantages also apply to women undergoing primary cytoreductive surgery. So that's a different patient population. The patient population consists of patients with stage 3 ovarian cancer who are eligible for primary CRS. And then we will compare the addition of HIPEC to CRS without HIPEC with primary outcome of overall survival. Here you can see an overview of the study design. It's a little bit similar to the OVHIPEC 1 trial, but there are some differences. In the first box, you see the patient population. So as I just said, stage 3 ovarian cancer. Patients can only be randomized if the complete cytoreductive surgery was achieved or with residual disease to 2.5 millimeters. Patients should have a performance score of 0 to 2. And the randomization will be done at the end of the cytoreductive surgery. Patients are randomized 1-to-1 to HIPEC or no HIPEC, and all patients will receive 6 cycles of carboplatin and paclitaxel. Carboplatin is administered every 3 weeks and paclitaxel either every 3 weeks or a weekly scheme. Also, if there's an indication for PARP inhibitors or bevacizumab maintenance therapy, that's also allowed in our trial. Follow-up for this trial will take 5 years. In the first 2 years, every 3 months, and in the last 3 years, every 6 months. And we will perform tumor assessments by monitoring the CA125 and performing CT scans and physical examinations. So the difference with the OVHIPEC 1 trial is that randomization is performed at the end of the CRS instead of upfront to surgery. So during the CRS, the surgeon or gynecologist doesn't know the outcome of the randomization yet. In this trial, both the open and closed techniques are allowed. So as we showed earlier on the right, you see the Colosseum technique, the open one, and on the left you see a kind of a cartoon of the closed technique. We use cisplatin in a dose of 100 milligrams per square meters, and sodium thiosulfate is used to protect the kidneys. The next slide is about the sample size calculation. We have a total calculated a total sample size of 538 patients, and we use the following factors to make this calculation. We used the estimation of survival of the control group from the Armstrong study that was published in 2006. That's almost 50 months. The efficacy of HIPEC was determined in the OVHIPEC 1 trial with a hazard ratio of 0.67 and a study duration of 6 years. And this was a condition of the Dutch funder of the trial. Interim analysis will be done after 67 and 133 events. And all of this together results in a patient total of patients of 538 And the primary analysis will be done after 200 events. And an event is death of all cause. Estimated accrual time will be 5 years and 1 year for follow-up of the last patient. Here I will show you 2 of the most important inclusion criteria for this trial. So the stage 3 primary epithelial ovarian cancer should be histological proven. Sometimes that's not possible before surgery, but then intraoperative frozen section material is also a way to prove this. There are some patients with stage 4 disease that we also allow in this trial. And that's, for example, when there's resectable local bowel involvement, abdominal wall metastases, or umbilical lesions. In case there is a sign of extra abdominal enlarged lymph nodes, the protocol says to either do pathology or a PET scan, which must be negative. And the second inclusion criteria that I would like to show again is that a complete or near complete surgery should be achieved. So only when there is no residual disease or residual disease up to 2.5 millimeters, then we will randomize the patient. Here you can see some of the exclusion criteria. For example, a history of previous malignancy treated with chemotherapy. And there are some exceptions for this. For example, basal squamous or squamous cell cancer of the skin. And also we allow if someone had a malignancy more than 5 years ago, and if this wasn't treated with chemotherapy. And of course, if primary site reduction is not feasible, then enrollment in this trial is not possible. And for this, we use the trust criteria to make this decision. This trial is supported by the GCIG and NGOT, the International and European Intergroup Societies for Gynecological Oncology. So it's an inter-trial group collaboration. And on this slide, I would like to show you our international collaboration. So here I show the trial groups, but I will explain which countries they are. So in the first line, you see the Dutch oncology group. We started patient accrual January last year, and 10 hospitals in the Netherlands are participating in the trial. The second one is France. They already started patient accrual in November last year, and they are now open with 3 centers, but they will extend until 10 hospitals. Then Italy and Scandinavia. In Scandinavia, Denmark and Sweden. We expect them to start accrual in June of this year. I see here it says that NSGO has started in June 2020, but it should be 2021. And Memorial Sloan Kettering Cancer Center in New York and Cancer Trials Ireland are expected to start accrual in September. The UK and Australia are also have started funding application, and they are planning on opening the trial in those countries too. Well, what is the current status of the trial? We have randomized 30 patients of the 538. COVID-19 has definitely had an impact on the trial progress and the patient accrual. As you can see, from March to June last year, the trial was on hold in all participating centers. That was during the first wave in the Netherlands. But after reopening, we gladly see increased numbers of accrual. And we are confident that we can reach the total number of 538 with the international collaboration that we're starting. However, to ensure surgical quality of this trial and to prevent that multiple sites will participate with a low accrual numbers, we set some criteria for centers that show interest to participate in this trial. And here you can see those criteria. The first one is that the center should be a member of a national trial group because it's an inter-trial collaboration. A center should have performed 20 cytoreductive surgery procedures per year for ovarian cancer. It should be an experienced HIPEC center. So we set the criteria that they did 10 HIPEC procedures before start of accrual. There should be a multidisciplinary team in the hospital consisting of a gynecological oncologist, medical oncologist, pathologist, radiologist, and often gastrointestinal surgeons to do the procedure together. And center must have own financial resources for the study treatment and be experienced in conducting clinical trials. So for example, have a clinical trial department for organizing all the study assessments. You have seen this slide earlier, but this is a more extensive one with the international collaboration. So this trial could only be realized because all of these hospitals, trial groups, funders, and hospitals are joining us in realizing this trial. So I would like to thank everyone that's doing its very best to make this a success. I would like to thank you, of course, for your attention and for the questions. I'll be there at the end.
That's a most interesting and eagerly awaited trial because you know that everybody want to jump into HIPEC in upfront setting in primary cytoreductive surgery, and the final proof of pudding of HIPEC is this trial. I think not just gynecologist, oncologist, all the colorectal, pseudomyxoma, mesothelioma, everybody is waiting for this trial. That's fantastic for devising this trial, and hopefully we hope we'll have the results soon and you'll have an excellent outcome. Thank you very much.
As soon as possible.